from Addis Ababa University, Department of A&T. I'm delighted to be part of this first edition of International Cancer webinar. For today, I'll be speaking on one of our recent researches on the descriptive epidemiology of nasopharyngeal carcinoma in the Anbessa hospital, which is one of the largest hospitals in Ethiopia. So me and my colleagues have tried to study the clinical patterns, the clinical pathological patterns of nasopharyngeal carcinoma. And this study was published in May 2021, and the number and the link is also available online. As an introduction, nasopharyngeal carcinoma is a malignancy which arises from the mucosal epithelial lining of the nasopharynx, especially from an area known as fossa of Rosenmuller, which is found on the lateral aspect of the nasopharynx, just medial to the opening of the ischian tube. The male to female, it's more commonly seen in males. The male to female ratio is around 2 to 3 to 1. The incidence of NPC is not yet studied in Ethiopia, but we have found one study which is done in 2015 based on the cancer registry data of Addis Ababa. And on this study, NPC has been found to be the 5th commonest cancer in males. And worldwide, there are these high incidence areas like parts of China, southern China, Southeast Asian countries, North Africa, and parts of Canada and Alaska are considered the high incidence areas. And nasopharyngeal carcinoma also shows some ethnic predisposition. For example, the Cantonese tribe or ethnic group has a higher incidence among the Chinese population. This is the data derived from a study published on Lancet in 2019. The areas that are shown in dark blue are the high incidence, or what are known as the endemic areas. Globally, the highest incidence in the world is seen in China, followed by China. The highest incidence is next to China. The highest incidence is seen in other Southeastern Asian countries like Indonesia, Thailand, Vietnam, and Malaysia. And some countries of Northern Africa like Tunisia, Morocco, Algeria are also considered to be high incidence areas. And recently, Sudan and Kenya have been included in this high incidence group for nasopharyngeal carcinoma. The WHO has classified NPC into mainly the keratinizing squamous cell carcinoma and the non-keratinizing types. The non-keratinizing type is further classified into differentiated and undifferentiated types. And there is also a third variant, the basaloid squamous carcinoma. This one is actually a very rare variant and has been recently recognized. And for today, our discussion will mainly focus on the keratinizing and non-keratinizing malignancies. So the keratinizing squamous cell carcinoma, or the WHO type 1, shares mainly similar characteristics with the other head and neck carcinomas, even having similar risk factors like smoking, heavy alcohol intake, exposure to radiation, even age. It's commonly found in the elder age group. And it's also the commonest histopathologic type in non-endemic regions like Europe and US. The other histopathologic type is the non-keratinizing carcinoma, the differentiated type, or the WHO type 2, and the undifferentiated subtype, which is the WHO type 3. This non-keratinizing carcinoma is seen in high incidence areas, and it highly correlates with raised EBV titers or serologies. Here are some identified risk factors for nasopharyngeal carcinoma. The most studied one is Epstein-Barr virus infection. This is an infection which is usually acquired during childhood, and the EBV virus usually infects lymphocytes and epithelial cells, and usually remains as a latent infection, and almost 90% of the world population is assumed to be a carrier. But among this 90%, almost only few patients, only few individuals tend to develop the carcinoma. So now the current assumption is that maybe this Epstein-Barr virus is associated with other, requires other carcinogenic cofactors, which might lead to progression of this nasopharyngeal carcinoma. The other risk factor is high consumption of locally preserved foods. The most studied one is salted preserved fish, which is consumed among the Chinese population. Historically, this salted fish was used to wean babies from breastfeeding, and populations of some communities of the North Africa and Arctic region have also similar food where they have salt preserved meats. These preserved foods in general share common carcinogens like the nitrosamines. These nitrosamines are highly carcinogenic and contain EBV activating substances, Epstein-Barr virus activating substances. The other non-dietary environmental risk factors are domestic exposure to indoor smoke from burning wood or incense, occupational exposure to smoke and chemical fumes. Other less common risk factors are family history of NPC and smoking, especially in the elderly group. So our study was mainly conducted in Anbessa hospital. It's one of the largest referral hospitals. Until recently, it was the only hospital which provided radiotherapy service for cancer patients. So almost all the cancer patients are referred to this hospital. So that's why we chose it as one of our study areas. The study was carried out from September 2017 to October 2020. It was a hospital-based retrospective descriptive study. The data was collected through medical review of charts. So basically all the basic demographic characteristics where data was collected, and the pathology results were also revised. So we tried to only include squamous cell carcinoma of the nasopharynx, which is directly obtained from the nasopharyngeal specimen. And we also tried to exclude other nasopharyngeal malignancies arising from the mesenchymal tissues of the nasopharynx, like rhabdomyosarcomas, lymphomas, melanomas, and the likes. The clinical stage was determined based on imaging and clinical presentation, and it was done according to the AGCC 2018 classification. A total of 318 medical charts were reviewed of the cases which presented during the study period. And there were a total of 71% males and 28% female patients. The male to female ratio was around 2.5 to 1. Males still outnumbered the female patients, which is most common and consistent finding in all nasopharyngeal studies. Our youngest patient was 13 years old and the oldest one was 81. The mean age at presentation was 37 with a standard deviation of plus or minus 15. The peak age at presentation was 20 to 39 years of age, which includes almost 44% of the cases. And we observed a significant number of juvenile NPC cases. We took the cutoff for juvenile age group for those younger than 30 years of age. So this group represented almost 34% of the studied cases. When we see the age distribution with respect to gender, males, females had a peak in the second and third decade of life from 20 to 40 years of age, while females, while males had, I'm sorry, did I say female? The females had a peak from 20 to 40 years of age, while the male patients had two peaks. The first peak was in the third decade, and the other peak or age of onset was in the fifth decade. And for both groups, for both male and female, the number of cases significantly declined after the age of 60. Here is a regional distribution of our cases. Most of our cases came from Oromia region, which was around 38%. The rest of the regions had almost smaller proportions. When we compare this to the population density of each region, it was somehow comparable to what is expected. So the higher percentage seen in Oromia region reflects the higher population density in this area. Majority of our patients were in advanced stage. Almost 56% presented with stage 3 and almost 30% presented with stage 4 disease. The histopathologic results had showed a predominance of the non-keratinizing type, which was almost 94%, while only 5.7% of them were keratinizing squamous cell carcinomas. And among the non-keratinizing nasopharyngeal carcinomas, almost 85% of them were still undifferentiated type, and the rest, 8.4 were grouped as differentiated non-keratinizing carcinoma. So now I'll try to discuss some of the pertinent findings of the study in relation to other studies. I will try to go through some literatures. So some of the findings of the study were the bimodality of the peak age, the young age of onset, the high number of juvenile NPC cases, and the predominance of non-keratinizing nasopharyngeal carcinoma. So in general, the bimodality in the age distribution and younger age of onset are common features in endemic parts of the world. So to look at some literatures, there was an epidemiological study in Malaysia, which is also a high incidence and endemic country. In this study, the incidence increased after the age of 20 and reached maximum or plateau between 40 to 49 years. And there was no further rise after the age of 60 years of age. And in another study of the North African Maghrebian country, or in one of the high incidence regions, the age at diagnosis of the cases ranged from 11 to 81 years, with a clear bimodal distribution, with a peak at 20 years and 40. Just to mention another literature, in a Nigerian study done at the Ibadan Cancer Registry, the mean age was 41 years, and the peak age group in the females was 20 to 29 and 50 to 59 for males, with a rapid decline of cases after the age of 60. So as we can see, this studies done in this high incidence regions have showed somehow a similar pattern to our study. And in general, the bimodality of the age distribution and the young age of presentation is attributed to one, to the early age environmental carcinogen exposure, like it may be a dietary exposure or other environmental exposure. The other thing is it might be due to a probable chronic Epstein-Barr virus infection, which is acquired during early childhood. And on the other hand, the rapid decline of cases or incidence after 60 years of age indicates that NPC is less likely associated with the usual risk factors associated with other head and neck carcinomas, like heavy alcohol intake, smoking, chronic infection. Age may not be directly related or may not be implicated as a risk factor for nasopharyngeal carcinoma. So in general, juvenile nasopharyngeal carcinoma is not common, especially in those under 20 years of age. And there was one study which compared the Asian NPC with that of the North, with that occurring in the northern part of Africa. And in the northern Africa, there were 20% of the patients were below the age of 30, which was an unusual finding. Whereas in the Asian NPC, which is another high incidence area, most of the cases were segregated in the middle age group. So our study is somehow parallel, had somehow parallel finding to that of the North African age distribution, where there are significant number of juvenile cases below the age of 30. So this higher incidence of juvenile cases reflects that there might be a possible genetic susceptibility. So whenever we come across these juvenile cases, it's better if we incorporate genetic testing and we try to dig into the family history while evaluating the patients. And advanced stage at presentation is also another feature of undifferentiated nasopharyngeal carcinoma, undifferentiated non-keratinizing carcinoma. This histologic type is known for its aggressive course, it rapidly spreads into the adjacent tissues. It has a rapid local regional spread. Therefore, patients tend to present at an advanced stage earlier than the other pathologic variants. The other finding was the predominance of the non-keratinizing carcinoma. As I said earlier, we had almost 94% of our kids were almost non-keratinizing type. And in general, in high incidence areas like China, North Africa, and Indonesia, almost all cases were non-keratinizing type, especially the undifferentiated type. And these non-keratinizing neoplasms are highly correlated with chronic subclinical EBV infection. And as I said earlier, this EBV carrier state is very common. So we need to look for other carcinogenic cofactors, because EBV by itself is not a sufficient cause to lead to this malignancy. So we need to search for other environmental or genetic factors. So as a conclusion from our study, in our study group, nasopharyngeal carcinoma was common in the young and productive age group, which will have its own socioeconomic implications. And the clinical pathologic pattern was somehow similar to that of the endemic areas. So it was a single institution study, and it doesn't reflect the true distribution of the disease in the country. At least it will give insight what the epidemiological pattern looks like in our setup. So with this, we can see that Ethiopia is still an explored region regarding this malignancy. And it indicates that the findings indicate that Ethiopia may be one of the possible emerging endemic regions for nasopharyngeal carcinoma. So with all this, we invite all interested researchers to participate in future large-scale studies that are planned to investigate and research more on this malignancy. So with this, I will wind up my presentations. Thank you. Have a good day. And if you have any questions or comments, you're very welcome. Thank you.